Ik ga over in het Engels. It's an honor to introduce to you our first international keynote speaker of today. Is Professor Dr. Neil Greenberg. He is an academic psychiatrist who served for 23 years in the British Army, where he developed trauma risk management, for which he also was awarded. And he specialized in understanding and management of psychological trauma, on PTSD, and occupational mental ill health. Greenberg is working at the King's College, London, and was also the former president of the UK Psychological Trauma Society, and runs the psychological health consultancy March on Stress. I have a lot to say about you, so 12 more minutes. During the COVID pandemic, he was part of the NHS England and Improvement Wellbeing team, and contributed to the national response to protect the mental health of NHS workers. And I believe that in view of the current situation in Europe with the COVID pandemic and the war, it is his experience in both of these fields will be highly relevant to us. So please give a warm welcome to Professor Neil Greenberg.
Thank you very much. Thank you ever so much for inviting me. I've obviously been sitting in the audience this morning, and I must admit I haven't understood quite a lot of what's been said, unsurprisingly. So I hope you understand me better than I might have understood the other speakers. And hello to people over there as well. This is very strange, as I'm sure other speakers have probably said. You've already had the introduction, so you don't need to hear all that again. I put my Twitter handle up there for those of you, the papers that I'll talk about. If you do Twitter, then by all means do follow me, and we try and pump out our research from there as much as we can. I guess the thing I would say from my sort of bio is my particular interest over the years, developed in the military, but since that time as well, is in occupational psychiatry. And certainly in the UK, one of the challenges for many mental health professionals is they do a great job of getting patients better, which is of course what we do, but sometimes they don't think about work as one of the treatment objectives. And I'm very passionate, because I think work generally is what most of us do much of the time, to try and encourage, wherever possible, getting people back to work as being something that we should aim for, even, as you may know, for people who even have very, very serious mental health disorders, schizophrenia being a good example. Just very briefly, these are the areas where, if you like to look at the academic work, you can download most of our papers, particularly the King's Centre for Military Health Research, which is at King's College London. We have a good website on there with a list of all our publications that you can download for free, so just don't tell the journals, thanks. So today I'm mostly going to speak about trauma and what can be done within organisations, including healthcare settings, but not just healthcare settings, to try and improve people's mental health. But it's fair to say that if you're in a workplace where you're predictably exposed to traumatic events, child social worker, emergency services and the like, you still have to think that the biggest cause of mental health problems at work actually isn't the trauma that people see. It's the day-to-day grind of being in the workplace. So in 2010, I was the psychiatrist for the British military, going out to Afghanistan to support our troops, meeting some great Dutch psychiatrists out there as well. Eric Vermetten, I don't know if any of you know him, he's a good colleague of mine. Anyway, I digress. But when you're out in Afghanistan speaking to troops who have seen horrible stuff, and you say, why are you coming to seek help? Mostly it wasn't my buddy died in my arms, or I saw this terrible sight. Mostly it was, my spouse doesn't love me, I have too much work, no one appreciates what I do. All the stuff that you would see day to day, whether you're in Afghanistan or whether you're in Utrecht, it would be no different. And we shouldn't also forget that things at home also have a massive impact on people's ability to have a good mental health in the workplace as well. So this is a slide from the UK NICE guidelines on the management of PTSD. And this is a group of people who were subject to armed robbery. So I think we'd probably agree that's a pretty reasonable traumatic event. And what you can see is on the bottom there, you can see the number of weeks since the armed robbery. And on the up and down y-axis, you can see the percentage of people who report all the symptoms that are classically associated with PTSD. So poor sleep, concentration, avoidance, all that kind of stuff. And what you can see straight away is 60% of people exposed to an armed robbery develop lots of symptoms. That won't be surprising to you. But notice also that 40% don't. So isn't it funny that the first thing that happens after an armed robbery could be you thinking, I wonder what's for dinner, or these shoes are a bit tight. You know, not everybody thinks, it was terrible and does what happens on the films. But many people do. And as you can see, most of those people recover over 4, 6, 10, 12 weeks. And they recover because of natural processes that we all do when we go through adversity. They go for a run, they speak to people, they have a glass of wine or two, and they let some time pass. And that's what gets most people better. And then you're left with this long tail here of people who have probably got PTSD, in this case about 10%. But it's really important that what we don't do is to label those people in the early stages of being exposed as being ill. Because these people aren't ill. We get beyond what we can talk about today of what's the benefit of being distressed. But there probably is some. But this is non-pathological, and this doesn't need treatment. So that's what we call a type 1 trauma, which is a single incident event. But actually, many occupations, and healthcare is a great example, actually have more exposure to what we call type 2 trauma. So the type 1 trauma, the road traffic accident, the bomb blast, the dog bite, takes you from functioning pretty well to not functioning very well, usually in a pretty rapid timescale. But if you've got someone who's a child social worker and they are regularly seeing every day this really horrible stuff, hearing unpleasant stories, seeing children who have been in really challenging situations, gradually they can go downhill. And they go downhill and no one really notices. Because every time someone says, how are you doing? They say, oh, I'm fine. And do you know what FINE stands for? Which is fucked up, insecure, neurotic, and emotional. So if someone tells you they're fine, I would be really worried. Of course, it can mean they're okay too. But the fact is, people haven't had a proper conversation. And these people go gradually downhill. And then their manager says, well, do you know what, Neil? We're going to move your chair from over there to over there. And Neil goes, that's it. I'm out of here. I've had enough. And everyone says, well, what's up with Neil? We're going to move his chair. But actually, it's because they've been going gradually downhill. And this type 2 trauma, it's specifically recognized in DSM-5. It mentions a routine exposure to traumatic events at work as one of the criteria. And it is really applicable to many, many occupations, actually far more than you might think. I mean, even, for instance, train drivers, unfortunately, I'm sure it happens in the Netherlands as well. But in the UK, train drivers, unfortunately, have people who throw themselves in front of trains, not uncommonly. So actually, trauma can happen in the workplace for many, many occupational groups. Just a topic just to bring up, which is particularly relevant, I think, since the pandemic, although it's been around for a long time, is moral injury. And I don't know if you've heard of moral injury, but it describes the strong emotional reactions that we can have, often anger, shame, guilt, or disgust, when we're put in a situation where our moral or ethical code has been broken. So I'm an intensive care nurse. I'm used to dealing with one patient, providing them with really high-quality care. Sometimes they die, but I do my best to keep them alive. The pandemic happens, I've got 6 patients. I can't give those 6 patients the care that I gave one patient. I shouldn't have been put in this position. The patient dies. You know, if I had time to spend with that patient would have survived. And you get put into these really challenging situations which often has no clear answer. Now, the key thing about moral injury is it's not a diagnosis. You won't find it in ICD-11 or DSM-5. It falls into the same category as what we might refer to as burnout, which is sort of a syndrome. But the important thing is that we've shown that actually if you are suffering with these strong emotional reactions from moral injuries, you are at much increased risk of suffering post-traumatic stress disorder, depression, and unfortunately suicidality, which we've published on. This is a big study we've got going at the moment called NHS Check, which has got about 25,000 healthcare workers across 18 hospitals in England. And what we did here is we measured various mental health scales, and you've got GHQ, which is general mental health, depression, anxiety, and PTSD. But we also measured exposure to potentially morally injurious events. So how exposed were they? And what you can see here is the highest group, the group who are most exposed to these morally injurious situations that have the highest risk of having PTSD and other mental health problems. So why is that important? Because in the workplace, if you've got staff who are constantly saying, that's not right, this should never have happened, we should never have been asked to do this, those people are at substantially increased risk of also having a diagnosable mental health disorder. So what do we do about mental health in the workplace, particularly related to trauma? And what we try and do is to try and follow a preventative medicine approach, which is, prevent it, detect it early, or treat it. So in terms of preventing mental health problems occurring in the workplace, what we know is the most important thing is to have teams that are as cohesed and supportive as possible. So this is data from British troops in Iraq in 2009. We went out and we measured their mental health whilst they were doing the doing. So they were on the ground, dealing with difficult and traumatic situations. And we measured a traumatic stress scale. This is the PCLC, if you know the post-traumatic stress disorder checklist. But what we showed here is that teams who felt more connected to each other had much lower levels of traumatic stress symptoms, regardless of how much trauma they were exposed. But the real money, the real here, is on the impact of supervisory level leaders. Now, this is vital in lots of organizations. And by supervisory level leaders, what I mean is the most junior leader you might have. So on a hospital ward, it's the nurse who's in charge of that shift that day. So it's great what the senior nurse or the chief medical officer or the chief executive thinks. That's really important. But it's the person on a day-to-day basis who influences your life that makes a huge, huge impact. So this is British troops, Afghanistan, 2010. Just less than 3% of those troops probably have PTSD when we measured their mental health. Not surprising, they're in a war zone. But you can see here that in red, forgive me, I'm slightly colorblind, so I think it's red and green, it usually is. The red, about 0.6% of people who said that their immediate supervisor was supportive probably had PTSD, whereas you had nearly 10 times that rate in the group who felt their immediate supervisor wasn't. That's a 90% reduction in probable PTSD as a result of having a supervisor who is supportive. Although this is associative data, so we have to, causation isn't here, we accept that. We'll come back to that in a minute. Another really important point is about how well trained you are to do your job. Now, of course, most organizations want people to be effective because that's good to deliver output. But what we know is that troops who feel that they are unable to do the job, they're not trained properly, are much higher risk of having mental health problems. The Kisley et al. Paper looked at healthcare workers. And again, healthcare workers who felt they were acting outside of their normal scope of work were at substantially increased risk of mental health problems. Now, during the pandemic, I'm sure it's been the same in the Netherlands as it is in the UK, many healthcare staff have been asked to do jobs that are completely different to what they've normally been doing. That puts them, again, at increased risk. Many organizations provide some sort of resilience training, it's often called. Things like mindfulness, which I'm sure you've heard lots about, and techniques such as the stop technique, and that's just an example of the stop technique there, which is a sort of simple technique to try and help you gain perspective if you're distressed. Now, these sorts of trainings seem to work for some people, and for the ones that they work quite well. But one of the dangers, and this is emerging research which we are still working on, is that what sometimes organizations also do is to provide long lists of symptoms that you might experience. So you're a police officer. If you see a nasty event, you might have nightmares. You might have recurrent thoughts about it. You might find that you're more tearful or emotional. Well, the emerging evidence there seems to suggest that rather than actually help, that sort of information actually may end up sensitizing people. So you're sort of telling people what's going to happen, and guess what? It happens. So if you're going to do preventative education, you're much better focusing on coping skills and how to seek help than you are on giving people a list of all the doom and gloom that might happen if they were to experience a reaction. But going back to those supervisors, the best evidence we have for training is for training up junior supervisors. So this was a study done in Australia with fire and rescue workers. And what they did here is they did a randomized controlled trial. And I don't know how well you know New South Wales firefighters, but they're probably not the most psychologically minded individuals you might meet. But unsurprisingly, they see lots of trauma. So what they did is train up fire station managers how to have what we call a psychologically savvy conversation, how to speak about trauma, how to speak about mental health, and how to get beyond fine, if someone says they were fine. And what they found is that for every pound invested in that training, it was published in a UK journal, which is why it's pounds and not dollars, they saved £10 on sickness absence over the following 6 months. So again, that's a 90% reduction in sickness-related ill health costs. So this is a really big impact of training up a supervisor how to speak to their staff about mental health. So when the pandemic hit in the UK, what we did is we designed a very brief intervention. This was 1 hour, delivered over Zoom in most cases, because like all of us, we couldn't get out to do the training. And it was called REACT. And what REACT stands for is recognize, engage, actively listen, check for risk, and talk about a specific plan. And what it was a brief training trying to give supervisors active listening skills to speak about mental health problems. We did a small evaluation, and what we found here was that before the training course, most of these healthcare managers, over half of them, didn't feel confident to really talk about mental health with their staff. 1 month later, 85% of them felt confident. This is from a 1 hour intervention delivered online. So what I'm saying here is a bite-sized, small piece of work to train up junior supervisors seems to have a substantially big difference. And as I showed earlier on, that's likely to help. Another thing that's often used, or aimed to be used, is screening. So we've got a group of people who are going to do this difficult task. What we'll do is we'll sit them down with lots of psychiatrists, and they'll ask them lots of detailed questions and give them some questionnaires, and we'll try and spot the ones who are more risky. Now, that's very seductive, because if you could do that, you prevent them becoming unwell. But it's really important, and I will come to this in a second, to distinguish between what might work in a community setting and what might work in an organizational setting. Because people in organizations are very suspicious often about what's going on, about if I want that job, am I going to answer the questions properly? And there's lots and lots of stuff there. So this is a great study, again, done in Australia, this time with police. They use the MMPI, which you probably know is a very comprehensive measure of psychopathology. And they use this at assessment. So when people join the police, they follow the people up for 7 years, which is a pretty good period of follow-up. And they found that the MMPI score at baseline predicted absolutely nothing in terms of psychopathology developed over the following 7 years. And we've got plenty of studies from our military, which again show the same thing. So the danger in pre-screening people is, although it's seductive, it makes you feel that you've done the right job, it doesn't pick up the people who have got problems, and actually ends up discriminating against people who actually appear to be unwell, but actually could have done the job perfectly well. Another way you can use screening, and this is used perhaps more commonly, is once something's happened. So after a major disaster, after the end of a pandemic, if we're at the end, hopefully we are, after a group of troops have gone on deployment. So what they do here, again, is to give out questionnaires, often have a psychological interview, and the aim here is to spot the ones who have been damaged in order to get those people to have help. So the US military started doing this in the early 2000s, and by 2007, they had screened well more than 1 million troops who had come back from Iraq and Afghanistan, with the aim of trying to protect their mental health. And they did an evaluation of it for the first time and published it in JAMA, which you probably know is a very good journal. You'd be happy to get your paper in JAMA. And they found a worrying finding. And the finding they found was that the troops who got screened and found to have a potential problem and then told to get help, the ones who got help did much less well than the ones who ignored the advice and didn't go and get any help at all. You were almost twice as likely to be ill in the long term if you got the help versus if you didn't get the help. Now, there were lots of reasons for this, potentially, but this meant that they needed to do a randomized controlled trial. They had to do that. But unfortunately, they couldn't do it because Congress wouldn't allow them to stop screening people to get a control group. And so the good news for us in the UK is they said, well, UK, you don't screen your troops. How about we give you $3 million and you do a trial in your troops? And we said, yeah, that sounds pretty good, actually. Yeah, well, say, any chance of 3.5? Anyway, no. So we only got 3. It was more than enough. So we screened 9,000 troops who came back from Afghanistan over about 3 years. We followed them up for 12 to 15 months. The screening group got a battery of questionnaires, and at the end of the questionnaires, it said either you're doing okay, looks like you've got a few issues, you should speak to your friends and family and padre, or it looks like you have a mental health problem, you should go and seek help from your medical officer. And the control group got nothing. They got, thank you very much for filling these questionnaires in. Our primary outcome was, were the screening group going to be better or not? We published it in The Lancet, and the short answer is it made no difference at all. So lots of time and effort and money, and there was no difference in terms of mental health outcomes between those who got the screening and those in the control group. Actually, I'll go back. And actually, it also didn't improve help seeking. So it didn't actually, people who got told to get help weren't any more likely to get it either. Now, this is really important because in organisational settings, there is a big call for screening quite often. After the Germanwings plane crash in 2015, the European Aviation Safety Agency have mandated that you must screen aircrew for mental health problems. Now, I understand the impetus behind that, but what I'm telling you is all the evidence we have says this is not going to protect anybody. And so we have to be really cautious that we don't jump into something that seems nice unless we've got the evidence to support it. What we do know seems to make a difference is trying to make sure that within the workplace we have the ability to detect people who might have mental health problems. And this was a paper, a Delphi study we did now 10 years ago, looking about what peer support should be doing. Because many organisations have peer supporters, they have well-meaning people within the organisation. And the view here is that peer supporters should be able to listen to what people are telling them. That goes without saying. They should be able to provide very practical support, identify people at higher risk, and get those people pushed forward to professional mental health support if they need it. And one of the programs that kind of in the introduction said I set up in the British military with colleagues, and is still running very strongly, is the TRIM program, which is a peer support program designed to try and help organisations deal with traumatic stress. The aim here is not to provide lots of mental health professionals flying into organisations, but instead what we did was to train up frontline Marines, sailors, soldiers, air personnel, how to have a conversation with their colleagues, spot if they're not doing okay, and if they're not doing okay, support them in a very broad sense, check in on again about a month later. If they're still not doing okay, then you put a metaphorical arm around them and say, let's get you to go and see the doctor. This is very much based upon the research that we did looking at military peacekeepers. So this is military personnel who have come back from doing difficult operations, humanitarian and peacekeeping operations. And we said, who did you speak to about your experiences? Guess what? 97% said I spoke to people just like me, who went on the same deployment, understood the same language. Only 8% said they went and spoke to medical or welfare services. So it's great if you have organisations with counselling services and employment assistance programs and the like, but most people don't speak to them or use them. Most people speak to their colleagues. So why wouldn't you place your detection system in the place where people are speaking to them already? So the TRIM course takes a couple of days. We train up staff how to have active listening skills, conversation, what to look for, very basic levels of support. We don't teach them about giving group hugs. Some of our Marines do some funny things, but that's another story. And we're certainly not training to be diagnosticians or counsellors or therapists. This is about trying to help people have an active conversation and know what to look for. And we've now published 14, well, there now are 14 published papers on TRIM, including a randomized controlled trial. This is not penicillin for trauma, but this is an absolutely credible way of improving help seeking, of improving social support, and actually decreasing the chance that people will have long-term problems because we get them to professional help early on. And the really good news over the last 2 years is that our health service has been buying into this. So we now have over 50 healthcare organisations who are using TRIM as a way of supporting healthcare workers who have obviously been exposed to very difficult situations. And there's a paper published on healthcare workers and TRIM last year, which didn't involve me, which is very nice. So, it was as independent as it can be. The last thing I want to mention in terms of what managers should do is about how managers should manage someone who is distressed. And I can tell you in most workplaces, if someone's crying and distressed, most managers would say, well, why don't you go home and sort yourself out and come back when you're feeling okay. And unfortunately, that's not the best approach. So the PIES approach, which was started in the military well over 100 years ago now, is the way that the military used to manage people who have acute distress on the battlefield. But these principles, the PIES principles, are just as applicable to other workplaces as well. There's a paper down there that you can sort of see, which comes from the American Journal of Psychiatry. The Israeli military had lots of stress casualties, and basically in the Lebanon War, 1982, they applied the PIES principles. They followed them up for 20 years. You don't get many 20-year follow-up studies. And they found the more the PIES principles applied when someone was distressed, the better their outcome was 20 years later on. So P stands for proximity. And that basically means if you've got someone who's distressed, you don't just send them home. Instead, you support them properly at work, you change their duties around to make them slightly less difficult to deal with, and you try and keep them close. In the First World War, the phrase was, keep them within the sound of your own guns. These days, it would probably be keep them within the sound of your own keyboards or mobile phones or something like that. Immediacy says that if you've got someone who's having a problem, you need to deal with that early on. You remember my type 2 trauma graph? If you can deal with the problem before it gets to the straw that breaks the camel's back, it's a lot easier to do the interventions. And all the research that we and other people have done say that when people seek mental health support, they often do so when it's got to a terribly difficult stage or they've hit the wall, and we want to get them upstream. Expectancy says that if you've got people who are having a difficult time and they've got some symptoms, that's probably normal, at least at first. If it's not impairing, if it's not getting worse, and actually if it's getting gradually better, and what we shouldn't do is over-medicalise them. The other side to it, though, is if things aren't getting better, if it is getting worse, then we need to have the expectation that they will get to professional help. And then the last principle is the principle of simplicity. If you probably have many experiences yourselves where you don't get good sleep and you're irritable and you're ratty and you can't make good decisions, guess what? You don't need a course of cognitive behavioural therapy. You need to get some good sleep. It might be a weekend off. It might be a chance to relax. If you've got a machine that you're really worried about because you can't use it and you're anxious, you don't need CBT for the anxiety. You need to learn how to use the machine properly. So simple things make a big difference. And then the last piece here of the strategy is to make sure that where we provide formal interventions, that they follow evidence as well. And one of the things that certainly still, unfortunately, is used in the UK a bit is psychological debriefing. And as you are hopefully probably aware, most of the international guidance, the UK, but also the Australian and the international guidance from the ISTSS, all say do not use psychological debriefing. So the idea of flying mental health professionals into the workplace after trauma is seductive because you kind of think you're making people better, but the evidence is not only does it not work, it actually stands a chance of making people worse. Unfortunately, us mental health professionals are great at dealing with patients. We are perhaps less good at dealing with people who are ordinarily distressed, and we can end up turning them into patients when that's not where they were going to be going. And the last thing I'd say, leaving a bit of time for questions, if that's okay, is that be wary of snake oil salesmen. I don't know if you use that phrase, but there's often people who come up and say, oh, I've got this really good one-shot trauma cure. And you say, well, that's great. Well, where's the evidence for that? Well, we haven't got any papers, but we've got lots of testimonials. We've got lots of people who say it works. Well, testimonials is not the same as, unfortunately, a paper in a decent journal. And I'm not saying academics have got the answer to everything, but you have to evaluate programs, particularly going back to that debriefing, because if we get it wrong, we may end up actually, unfortunately, causing more harm than good. So overall, most people exposed to trauma in the workplace will cope. However, many will be distressed in the short term. The ones who become unwell, unfortunately, probably won't seek help. We know stigma is a big problem. There are lots of evidence-based approaches, and overall, the best thing you can do is, in the workplace, improve support and reduce pressure. And that's not a healthcare intervention, that's a managerial supervisory intervention. This is a bit of a cheesy phrase, but there's often a discussion point about resilience and how resilient Sandra or Peter or Neil is. And actually, that's not very helpful. It kind of places the blame on the individual for being resilient or not. Within organizations, resilience often doesn't lie in individuals. It lies in the bonds between them. So the better bonds that you can create within the workplace, the better relationships between colleagues and supervisors, particularly in relation to mental health, the chances are the better the mental health of the workforce will be. That's me. I don't know if it's okay to take questions for a couple of minutes. Thank you. Thank you.
Thank you very much. I think it's highly relevant. Also, we have a shortage on people to get in our organizations, and I think burnout is also a commonly heard problem. We normally here do no questions of the keynote speakers, but maybe that's a bit Dutch from our conference. So if there's really one important question we can ask you,
I can give you some advice. I can give you some advice on haircuts instead if you want.
It's a bit stressful, perhaps.
The lights are on.
I'm looking at it, but I think we have no questions so far. Okay. Of course, I think there are a lot of questions, but thank you so much for taking the effort to come here.
That's okay.
Really
thank you very much.
There's a question, sorry.
Oh, there's a question. There's a question.
Is there a question?
Oh, yes. Go ahead. Yes? So yeah, well, it's absolutely the case. So alcohol misuse, depending on how you measure it, if you use the audit, which is the standard questionnaire that most of us use, then actually using an audit score of 16, which is alcohol misuse rather than just hazardous use, probably somewhere in the region of about 16% of British military personnel would meet that criteria. And it is absolutely higher in people who have been deployed versus those who haven't been deployed. What's been very interesting over time, because we've got sequential measures, we're now in our 4th wave of data collection, is that actually the rates of alcohol misuse have been going down. They're still higher than the civilian population. But as the rates of alcohol misuse have been going down, the rates of PTSD reporting has been going up, which does sort of lend some support, bizarrely, to the fact that alcohol's used obviously to self-medicate against PTSD symptoms, but actually maybe it's been successful. We see the ones where it's not successful. Clearly, they come to us as patients. But what it seems to suggest is many people are using some alcohol and actually it's working for them. And as we reduce the alcohol in the population, then the actual rates in the population of PTSD appear to be going up. Thank you.
Thanks for the question.
Great.
Actually, this part is...
Thank you very much. Sorry I wasn't okay.
Thank you very much.